Okay. So strokes like this will often cause motor deficits, upper motor deficits, meaning that it's motor neurons in the cortex itself that are causing problems, so they can't control the body movements anymore. Often they'll have speech deficits, either difficulty initiating speech or difficulty actually making the motions, the motor movements to produce speech. They may have other facial asymmetries, like half of their face is frowning, they can't smile, they can't move those muscles anymore. There's a whole wide range. There's a lot of cognitive deficits. And so it's really, neurorehabilitation is a really big field because more and more people, as we get an aging population, are experiencing strokes. And it's really important to continue to work because you can recover some function, not all function, even after a major stroke like this. The other thing that's really going to influence recovery or the amount of damage from a stroke is collateral blood flow. So this depends on where that occlusion occurred, whether there's other vessels that are also feeding the same areas. And so in a stroke like this, most of the damage is going to be here. You can see how it's actually kind of like an inverse wedge because there's vessels coming around that are feeding the edges of this area. So that's called collateral blood flow. It's good because it helps provide nutrients to the area that's losing its primary blood flow. But on the other hand, you do get some hemorrhage from that area as the blood vessels and cells in that area start to die. You can get hemorrhage. And so the red that you're seeing in here is actually bleeding into the area. That blood brings with it a whole bunch of proteins and enzymes that contribute to the damage in the area. So stroke is just a really tough disorder of the brain. Here is, stroke refers to permanent brain damage. And there's something called mini stroke. These are transient ischemic attacks. We're seeing a lot of people come into the hospital who have stroke symptoms, such as asymmetrical facial movements, slurred speech or inability to speak well, confusion, temporary paralysis or inability, weakness in part of their body. Usually it's on one side. But then those symptoms go away. So we call that a transient ischemic attack. Usually these symptoms last 10 to 20 minutes. And they're reversible. Whereas a stroke is irreversible. And here is imaging. Often if you can get to the hospital quick enough, they'll do imaging to see what's going on. So this is the internal carotid, and its primary branch is to the middle cerebral artery. It also feeds into the circle of Willis, which is that blood supply at the base of the brain. So it does also branch into the anterior and posterior cerebral arteries through the circle of Willis. But if there's plaque in the area, and right here you can see this area of narrowing, if there's an embolism that's coming up through the carotid, it can get wedged right there, and you'll lose blood supply to the downstream areas. Oftentimes, in your blood, you have anti-clotting mechanisms. So oftentimes, you'll break apart that clot before it causes permanent damage. So that's called a transient ischemic attack. But they're not benign, and they're really important to recognize because somebody who has a transient ischemic attack has a much higher risk of developing a stroke within a year. 14% of people with a TIA will go on to develop a full stroke within 1 year. And so what do you think you would do for somebody who comes in, they've had a transient ischemic attack, you do some imaging and you see that they have a narrowing here. They no longer have any symptoms, but you're worried that they might have a stroke, what would you do?
Look up here to see where you might get a clot come back.
So look up what?
Look upstream from the blood to see where the clot might come.
Right, so you see this in the brain, you're worried that other things may produce an embolism, so maybe you want to look at the heart, you could do an echo and look and see if there's atrial fibrillation or anything that would cause thrombus in the heart. You may want to look at the carotid arteries and see if you need an angioplasty to pull out plaque from the arteries. You could definitely do that. Make sure you decrease the risks. What else? I heard somebody over here say. Blood thinners, yes. So after a transient ischemic attack, if the person is a good candidate, you'll often put them on blood thinners to try to prevent future thrombi or embolism. If you go on to develop, if the clot doesn't clear, then there's a very stereotyped course of damage, much like we saw in the cardiac tissue. So with cerebral infarct, the first thing you're going to see, you get loss of blood flow, you're going to see those red neurons. And in this image right here, you can see here there's a red neuron. There's a red neuron. So those bright red cells in a sea of pink, those are dying or dead neurons. The other thing you see in this image is within the first day, here's the clot. And around the clot, what type of cell do you think these are? Right here, you see them all around this blood vessel. Yes, yeah, they're neutrophils. Neutrophils are your first cells that are going to come in with ischemic damage. And you can even see that you're starting to get a few inflammatory cells in the tissue itself. So the neutrophils are coming from the blood, and they are coming out of the blood vessels into the area of damage, the damaged tissue. Within a week, you have heavy neutrophil infiltration. You're also getting macrophages coming into the area. This is an activated microglia. What immune cell are the microglia? What is this guy's major job, you think? So the microglia, remember they're macrophages. They're derived from monocytes, just like macrophages in the rest of your tissue. So they're specialized macrophages for the brain. And microglia, when activated, act much like macrophages. You can see here that they have a large single nucleus, mononuclear cells, a lot of cytoplasm, and their job is both phagocytosis and secretion of cytokines to increase inflammation in the area. So they're signaling to bring in more neutrophils, to do cleanup, to activate astrocytes, to start the repair process, and increase vascular permeability so you get edema. All of the white area around here is edema. This one right here is an activated astrocyte. So the astrocytes are a lot like fibroblasts in other tissue. They can secrete growth factors. They can secrete extracellular matrix. And so they're really important in the repair process in the brain. And then if all the neutrophils are phagocytosing, and they're breaking down the tissue in the area and engulfing the waste or the necrotic tissue. Then finally, after 3 to 4 weeks, you have an area we call reactive gliosis. And it's formed with extracellular matrix and also astrocytes. So this appearance here, those are astrocytic processes. You see a lot of white space. That's kind of because we have a lot of contraction in brain tissue. What kind of tissue is brain? Is it permanent? Is it labile or stabile? It's permanent, right? So we can't regenerate most of the cells in the brain. So whenever you have a massive area of damage with reactive gliosis, you scar off the area, but then you get a lot of contraction. And you actually, unlike other tissues, you're left with a hole where that damage was. So the reactive gliosis is really kind of walling off the area of damage. So in the central nervous system, gliosis is a process akin to, think back to our wound healing. What do you think gliosis is akin to? Which of these? I'll give you 30 seconds to think about it, and then we'll take a poll. All right, how many people think inflammation? How many people think repair? How many people think resolution? And how many people think necrosis? Okay, so inflammation in the brain is still called inflammation, and it's the same as everywhere else in the body. Necrosis is a separate process. We still have necrosis in the brain. What kind of necrosis does the brain undergo? Liquefactive necrosis, exactly. What is resolution? Yes. So resolution is where you actually are able to fully heal the site. There may be a small scar or a small loss of function, but resolution is really back to normal function. And so with the skin, when you have injury to the skin, often you do have full resolution. Liver, you have full resolution. So in our regenerative tissues, the labile and stabile tissues, you get resolution depending on the amount of damage. In our permanent tissues, like cardiac and the brain, we have a repair process that ends up with scarring. And in the brain, we call this gliosis. So resolution occurs with only labile or stabile tissues, not with permanent tissues. Yes?
So, you say that is similar, is it the exact same, mechanism, or?
It's a little bit different. Gliosis in the brain, because the brain is specialized, we can't regenerate any neurons. Astrocytes have a slightly different function than fibroblasts. But the overview, and there's different chemicals that are involved. The extracellular matrix proteins that are produced are different. When you have scarring in the heart and repair in the heart, you actually fill in that space. And so it turns white, but that tissue, there's not a hole left in the heart. Whereas in the brain, you don't fill in the full tissue. So there are some differences between neural repair and repair in other areas of the body. All right, so the third type of cerebrovascular disease is hemorrhage. So intracranial hemorrhage, any kind of bleeding inside the cranial vault. Clinically, what do you think this is going to result in? Eventually death. Pretty morbid. So first symptom, Did anybody see Grey's Anatomy a couple of weeks ago? Where they were on an airplane and the guy fell over and bonked his head? I haven't watched it for a long time. I didn't know Derek was dead. But it was on at my parents' house, so I watched it. So remember they said he's bleeding into his skull, and what's her name? She had to go in and remove the blood. There it is, sorry. It's been a while. I used to watch it a lot, though. Right, so what was his first symptom? So headache, nausea, vomiting, dizziness. These are all signs of increased intracranial pressure. Yes?
So a lot of those symptoms are the exact same of a concussion?
Yes. So that is a good question. We're going to talk about traumatic brain injury in just a minute, but how do you tell the difference? And these are the same as hydrocephalus, and these are the same. Intracranial pressure is pretty much the pathogenesis for many types of traumatic brain diseases or brain injury. And you can't really tell the difference. If somebody just starts saying I have a headache and I don't feel well, it's really hard to understand what's going on. That's where history becomes very important. If you can talk to the person, that you can get some idea of what type of injury they may have sustained, if they were in a car crash, if they fell down. You try to talk to family members or people who were around. Did it predate with a seizure? You really need to rely on the history and the mechanism of injury to figure out what's going on. But you're right, most of the symptoms are the same for anything that's causing increased intracranial pressure. So hemorrhage can be caused, this bottom image here is showing you a hypertensive hemorrhage. This is a person who had extremely high blood pressure. We're talking 250 to 300 millimeters mercury systolic. So this is called a hypertensive emergency. And under that extreme of pressure, any blood vessel that has any kind of weakening can rupture. And that blood pools, in this case it's pooling at the base of the brain. That blood can't go anywhere because of the closed system, and so it's going to increase intracranial pressure. It's also going to increase pressure directly on whatever area of the brain it's against. So especially at the base of the brain, it can become very dangerous because the hindbrain controls breathing, it controls wakefulness, alertness, and so any kind of pressure down there can quickly lead to coma or death. The other major kind of intracranial hemorrhage will be an aneurysm. Anybody here know that they have an aneurysm? No? So in my anatomy class last semester, we were dissecting brains and we saw an aneurysm on the circle of Willis, and one of the students was like, I have that! And he had had an aneurysm rupture when he was 18. So a lot of us are walking around with aneurysms, and these are little outpouchings. They're actually quite common around the circle of Willis. And the anterior communicating branch between the anterior cerebral arteries right here is the most common place. But what it is it's a weakening in the wall of the blood vessel. And so there's two problems. One, it's weak, and it can rupture and cause bleeding into the brain. The other is that as blood pools here, it can form a thrombus, which can embolize to other places in the brain. So if these aneurysms rupture, and it can be under exercise, it could be with trauma, and sometimes they just rupture spontaneously. Usually what you'll hear from the person is, I had the worst headache of my life. The bleeding is in the subarachnoid space, which is the space between the arachnoid and the pia layers of the brain. And it causes, there's nerve endings in those the meninges, the areas surrounding the brain. So it causes a really bad headache in addition to these other symptoms, nausea, vomiting, dizziness. And it can, if it's not treated quickly, it can lead to coma. They're actually pretty good at treating these now. They can go in through, the student I had said they went in through his leg, all the way up through the heart, all the way up into the brain, and then they clip it. So they can just put basically a little clip over that aneurysm to block it from bleeding any further. Yes?
One of those ruptures, does the brain have a mechanism to fix it itself?
That's a good question. If there is a rupture, does the brain have a mechanism to fix it itself? If it's small, I think yes. There may be clinically silent aneurysms that leak a little bit. If it's a full rupture, these are arterial, and so the pressure is pretty high. So once you rupture, that pressure makes it really hard to repair. Venous breakages are much easier for your body to repair because the blood pressure, the blood flow is slower. All right, so let's go to traumatic brain injury, and this is related because brain injury can cause a lot of cerebrovascular disease. Brain injury is basically hitting your head, and we call that a blunt or some kind of penetrating injury. So penetrating injury, nail gun in the brain. I think there was a Grey's Anatomy episode about that. Stab wound, gunshot wound. You guys remember Gabby Gifford? So that's a penetrating brain injury. And these injuries can range in terms of clinical outcomes from silent, clinically silent, which means that there are no observable signs or symptoms, to, once again, coma and death. So the other way we classify traumatic brain injury, blunt versus penetrating, and closed versus open. So closed means that there's no fracture of the skull. Open means that the skull has been fractured at some point, someplace. And it doesn't, a blunt can be open. So you could have a blunt injury. You could fall and knock your head on concrete, and that could cause a skull fracture. So we would call that an open blunt injury. Make sense? Cool. So we divide brain injury into the areas that are affected. The first will be parenchymal injury. So the parenchyma is the brain tissue. And you're probably familiar with this. We talk about concussion and contusion are the two main types of parenchymal injury. Both of these are usually caused by blunt trauma, so an actual physical hit of the head to something. And the difference between concussion and contusion is that concussion is transient, temporary loss of consciousness, but it's reversible. The person goes back to completely normal, except for one thing. They usually have amnesia for the event. And a little bit of retrograde amnesia that tends to be proportional to the time they were out of it. So if you have somebody with a concussion who had lost consciousness for about a minute, it's a few minutes before the event is when they probably can't remember that far back. If they were out of it for about 10 minutes, it might be 20 or 30 minutes that they can't remember prior to the event. So the amount of amnesia correlates with the length of the loss of consciousness. The mechanisms of this are still not really understood. I was just reading about it to try to see what's new or what they know about it. And it looks like there's actually some axonal damage, twisting of the axons around the midbrain, between the hindbrain and the midbrain. So at the base of the brain, you have the reticular activating system. And this sends neurons up into the cortex, up into the rest of the brain, and it's responsible for consciousness. It's responsible for alertness, awakeness, attention. These are your neurotransmitters like norepinephrine and dopamine are coming from the reticular activating system. So these axons, with some kind of rotational force, get twisted and temporarily are not sending those signals up to the brain. And so that results in global consciousness. As long as you don't have too strong of rotational forces, which we'll talk about in just a minute, it is reversible and the person regains consciousness and goes back to normal. Now there's a big debate in athletics about concussions and how soon a player should go back out into the field if they've sustained a concussion. And this is a really active area of ongoing research because there's not much known. But we do know that repetitive blunt trauma, whether or not it causes a concussion, but especially if it causes concussions, leads to long-term brain damage. Cognitive deficits and early onset dementia are related to repetitive traumatic injuries. Yes?
Would that mean there's something not reversible going on with the concussion?
It's a good question. We don't know yet. I don't think there's enough information about what is exactly leading to dementia. Trauma is a risk factor for Alzheimer's disease. Alzheimer's disease is accumulation of proteins in the brain. So how do you go from reversible clinical symptoms to long-term building up of aggregates in the brain? It's a really cool question that I think there's, NFL is throwing a lot of money at it, so if you're interested in research, it's a good topic to go into.
This is going towards another conclusion.
Yes?
So can you get a concussion without the loss of consciousness?
That is another area it's a gray area. So if somebody has blunt trauma and temporary confusion but never a loss of consciousness, if in the emergency room, for example, or if they go see their athletic trainer, it's kind of variable. Some people say, yes, that's still a concussion and we need to treat it like a concussion and that player needs to be cognitively evaluated. Others will say, if there's no loss of consciousness, it's not technically a concussion. So again, it's another gray area. And I think you have competing interests in athletics, especially about when to draw the line when you call something a concussion. Again, because we don't understand the underlying mechanisms, it's hard to know exactly whether the outcomes for people who don't lose consciousness are the same as people who do lose consciousness, and whether to classify them together or not. So with a concussion, if you do brain imaging, or if that person happens to die and you do an autopsy, not die from the concussion, but from something else. If you do an autopsy, there's no brain changes. You don't really see much on imaging with a concussion. With a contusion, there's actually observable changes in the brain. So a contusion is kind of like a bruise on the brain. And I'm just going to go back for a second. So coup and contre-coup. But the actual contusion itself looks the same in both. But it's just, we name them two different things so that you can, the site of injury, the site of the actual blunt trauma is going to be exactly opposite from the contre-coup, the other side. And you want to know to look for damage in both. You don't necessarily get contre-coup. It really depends on how much backlash or whiplash there was associated with the injury. But what you do see is you see hemorrhaging. You'll see the cells in that area become damaged, may even undergo necrosis, and then you'll get edema. And this is a combination of cytotoxic and vasogenic edema. So the tissue injury is going to release cellular contents, that cytotoxic edema. As you get inflammation in the area, you're going to get vasogenic edema leaking through the blood vessels in that area. That's part of the hemorrhage as well. Another type of traumatic brain injury is diffuse axonal injury. And you see this with high rotational injuries. So there has to be some kind of rotational force. But this results in coma without any other signs. So you don't see a contusion, so you don't see areas of edema, but a person after some kind of traumatic injury has completely lost consciousness and they're in a deep coma. Most of the time, it's because of diffuse axonal injury. And even on basic histology, you won't see much. What happens is that there's shearing forces on the axons. And these are often the axons that are projecting up into the brain or across the brain. And as those axons become sheared, you have retrograde damage that goes up and eventually causes the cell to die. So those shearing forces globally cause neuronal death. So this is different than ischemia, but ultimately you do end up with neuronal cell loss. You won't see as much loss of all the other cells in the brain because it's really the axons that are damaged in this case. And then finally, we have vascular injury from trauma. So we talked about intracranial hemorrhage. This is intracranial hemorrhage as a result of some kind of trauma. And it can be penetrating or blunt, open or closed. And we can divide it into where the blood is pooling. So epidural hematoma is pooling, here's an example here, between the skull and the dura. Usually this is caused by some kind of, it's an arterial tear. So right along the skull are some major arteries. And if you have a skull fracture, it can tear one of these. So in this example, there's a skull fracture, and that causes a tear in the middle meningeal artery. And that artery will start to leak, and you'll get the development of a hematoma, epidural hematoma. Subdural hematoma is usually caused by tearing of the bridging veins. So these are veins that are going from the subarachnoid space into the dural sinuses. The dura actually forms these sinuses that drain both blood and CSF out of the skull. So there's veins that are going from the brain. They're bridging into those sinuses to be drained out of the brain. And as people age, or in very, very young kids, those veins are stretched because the brain is atrophied and kind of pulling away from that dural layer. So they're slightly stretched, putting them under tension. And so any kind of trauma, like a fall, which is somewhat common in the elderly, can cause those bridging veins to tear. And that'll cause leaking into the subdural area. So this is between the dura and the arachnoid layer. There's another one I didn't put on here, subarachnoid. I already mentioned it with intracranial hemorrhage. Subarachnoid hemorrhages, the most common cause are ruptured aneurysms or hypertensive hemorrhage. And then you can have intraparenchymal hemorrhage. So this is bleeding into the brain itself. And usually this will be caused by a stroke. You can have aneurysms inside the brain parenchyma as well. So it could be an aneurysm or other malformation of blood vessels. But usually it's caused by a stroke, and we call that a hemorrhagic stroke. So if a stroke is a loss of blood flow, how do you get a hemorrhagic stroke? How do you get bleeding into the area that's lost blood flow? Yeah, Ashley?
Is it from those vessels that are trying to bring in the blood flow, and then there's probably a rupture somewhere, and that causes the increased blood flow causes the hemorrhage?
Yeah, so those collateral vessels. Yeah, so the collateral vessels that are feeding the periphery are also now prone to damage as that tissue undergoes necrosis and leakage, and they can hemorrhage into the area of damage. So, thought question for you. Which type of vascular trauma do you think is going to show symptoms quicker? Epidural hemorrhage or a subdural hemorrhage, and why? I'll give you a minute to confer. Okay, what do you think? Yes? Yes. Great job. So epidural, remember I said it's a tear in an artery? Artery is under higher blood pressure. So when that is torn, you actually are going to get a faster growing bleed. So back to our Grey's Anatomy episode, the man on the plane hit his head. He seemed okay. He went and sat down next to his friend. And then about an hour later, he started to throw up. So he probably had an epidural hematoma. So with that, you have a lucid period that lasts for 1 to 4 hours, followed by symptoms. With a subdural hematoma, you get symptoms after about 12 to 24 hours. So subdural hematomas are much slower growing bleed. Many times they're not even recognized, especially because it happens in elderly, often happens in people who already have dementia or some type of confusion. And so on autopsy, you may see these organized hematomas in the subdural space that were never recognized and evacuated. With a subdural, a person within several hours their intracranial pressure will rise so high that they'll become comatose, and you need to get that blood out. All right, any questions? All right, I'm going to zoom through. Primary CNS disorders. So first of all, we have infections. I'll try to go through this area quickly because you guys have had micro. I think it was required, right? So you've had micro. You know what meningitis is. How would you tell the difference between viral and bacterial meningitis? Take a sample of the brain? CSF. So we do that with a lumbar puncture. Can go in right at the bottom of the spinal cord where it starts to fan out. That's called the cauda equina. You can put a needle in through the vertebrae, pull out a small amount of fluid. The first thing you want to look at is pressure. If there's an infection, you'll have an increased pressure. That pressure will be increased more with a bacterial infection than with a viral infection. You'll also see with bacterial, you'll see pus. It'll look yellowish. With a viral, we often call it aseptic because when you look at the cerebral spinal fluid, it's clear. And then you can look at cell counts. So the cell count is higher in bacterial, and it's mostly neutrophils. In viral, you do see some cells in the CSF, and they're mostly lymphocytes. There's increased protein in both, although more so in bacterial. Why do you think there's increased protein in the CSF? So that's part of it. The cells are lysine, so their intracellular contents are coming out. What else? Yes?
Will there be more protein because of the increased vascular permeability?
Yes, exactly. So with inflammation, remember vascular permeability increases, and you get protein leaking into whatever area. In this case, with meningitis, this is an inflammation of the meninges around the central nervous system. And so you'll get the vessels that supply the meninges increase, they're going to leak, and that protein will come out of the blood. Yes?
Are the symptoms for both bacterial? Bacterial that can be within 24 hours is really severe. Is viral the same way?
Viral is usually much less severe. So the symptoms are headache and neck stiffness. Those are the primary symptoms of meningitis. And it's more rapid and it's more severe with bacterial. Oftentimes, a viral meningitis may not even be diagnosed. Usually we call viral meningitis self-limited, so we put the person on supportive care, but we don't do a lot of treatment. With bacterial meningitis, you get them on antibiotics right away because it can rapidly turn into encephalitis and it can cause increased intracranial pressure, blah, blah, blah. You go on from there. The one that I think is really cool in thinking about mechanisms is that you have decreased glucose in bacterial infections and normal glucose with a viral infection. Why would that be? Yeah.
Could the bacteria be using the glucose as fuel?
Yes, exactly. So the bacteria and the lymphocytes are using up the glucose. And remember, you have, or not lymphocytes, sorry, neutrophils. With bacterial infections, you have a lot more inflammatory cells, mostly neutrophils. And so both of those cells, the bacterial cells and the neutrophils, are using up the glucose. Why don't viruses use up the glucose? Yes, they're not cells. That's right. Where do they get their glucose, or where do they get their energy? From their host cell. So they don't use up glucose themselves. They have to get inside a cell that's going to use up that glucose. Good, just a little review of micro. So meningitis is inflammation of the meninges. So you generally get pus built up in the subarachnoid space. Encephalitis is inflammation within the brain parenchyma itself. Most of the time this is virus. With bacteria, they tend to cause abscesses in the brain, and you can get abscesses in the brain. But encephalitis, the ones that you've probably heard of, are usually caused by viruses. So West Nile virus can cause encephalitis. HIV causes a type of encephalitis. Herpes virus causes encephalitis in some people. Rabies. All of these are viruses that get into the brain. You've all heard of Zika virus? In a healthy adult, it causes very minor symptoms. In a pregnant woman, if that virus crosses the placenta and gets into the developing fetus, there is a chance of microcephaly. So this image right here is a baby with microcephaly. The brain did not fully form. We're still figuring out the mechanisms behind it, but it is a form of encephalitis. So encephalitis can cause very severe defects. This is bacterial meningitis. Here, these are the meninges. So the pia is adherent to the brain. This is the brain tissue. And you can see there's blood vessels in the meninges, and that's how they become inflamed, they leak. That protein gets into the CSF, and the neutrophils get into the CSF. So there's tons of neutrophils all around here. It's not a really clean barrier, so if there is some inflammation that leaks into the brain, we call that meningoencephalitis. Without symptoms, you'd have to get, usually your body can take care of minor inflammation, so minor encephalitis, and the major symptoms are from meningitis. Because meningitis is so severe, we try to catch it and treat it before it spreads to become encephalitis. Yes?
What was that type of inflammation that you said?
Oh, meningoencephalitis. We just kind of merged the terms together. So what type of inflammation is this? This is meningitis, bacterial meningitis. What type of inflammation? Thinking back to your different types. This is purulent. And again, purulent inflammation tends to be with bacterial infections. It's where you have a lot of inflammatory cells, necrotic debris, dead bacterial cells. All of that is what forms pus. There's other agents that can cause disease of the brain. One is toxoplasmosis. This is actually a protist that can get into the brain. It's very common. A lot of us are infected with toxoplasmosis. As long as you have a healthy immune system, you usually don't have any symptoms. As soon as you become immunocompromised, you can get reactivation, toxoplasmosis. And so it happens with people who have HIV. You tend to get toxoplasmosis from undercooked pork. But the one I wanted to talk about was prion disease, because it's just fascinating. It's exceedingly rare, but the infectious agent in this case is the prion protein. Do you guys remember this from micro? I know Dr. Adams teaches it as well. So remember that we have PRPC. This is your normal cellular protein. And then we have PRPSC. PRP stands for prion protein. SC stands for scrapie, where it was first identified in sheep, which causes the disease scrapie. So PRPSC can actually, when it's next to a normal protein, can convert it into PRPSC. So it's a protein, it's not a virus, it's not a bacteria, it's not a protist, just a protein, but it can change the conformation of other proteins. This causes aggregates. And what I really wanted to point out here was the morphology. So this is the pathology that you'll see with prion disease. You do see red neurons. So what happens is these aggregates glom up against the cell and cause the cell to die. So they turn into red neurons, the neurons to die. But because it's not recognized by the immune system as danger, you don't get any inflammation. So the cells just die and then you get holes in the brain. So this is called spongiform encephalitis. And it happens very quickly once a person starts to develop symptoms. Within weeks to months, they progress from confusion, very bizarre behavior, coma, and death. Okay, now I want to move into some other disorders of the immune system. Does anybody know anybody with multiple sclerosis? A lot of people. Yeah, isn't that interesting? Multiple sclerosis, it seems to me, just observationally, is becoming a bigger and bigger problem. So what is multiple sclerosis? Those of you who know somebody with it, what do you see? What do they have? What is it? Their body's deteriorating. Yeah.
They can't move like they could before.
Yeah, they have motor weakness. So the deterioration is often felt as fatigue, motor weakness. Anybody know what the first sign usually is? Usually it's visual problems, either partial or total blindness. They'll also get tingling and numbness. But what's really interesting about multiple sclerosis is that these symptoms come and go. So a person may experience blindness for a few hours, and then they regain their vision. Yes? It can be anywhere in the body. So that's another feature of multiple sclerosis, is that these neurologic symptoms are widespread. And they're often, we call it relapsing, remitting. So a person will have some symptoms, and then they'll go into remission. And then they might get more symptoms, and then they'll go back into remission. And we don't exactly know what triggers those relapses. But what is the underlying pathology or pathogenesis? Does anybody know of multiple sclerosis? What's being, yeah?
It's the demyelinization of nerve cells.
Yes, this is a demyelination. And importantly, in the central nervous system. So optic nerve is often one of the first sites. You have, so it's affecting the axons. So it can affect motor areas. Question over here, Ian?
Wasn't the relapsing and remitting related to the various demyelination of neurons and then the compensation of various proteins in the neurons or the axons just for that?
It has to do with the pathology, the underlying pathogenesis of it. So what happens, you have demyelination, the axons tend to be okay. And what you'll get is these plaques. Do you guys read about the plaques or have heard of the plaques? So you get plaques. And these are made up of lymphocytes and macrophages, plus myelin debris. And often when you have these plaques, it's interrupting neural transmission. So that's why if it's in motor neurons, you get motor weakness. If it's in sensory neurons, you might get numbness and tingling. If it's in optic neurons, you might get visual field disturbances. Once these plaques go away, for reasons we don't quite understand, the inflammation will go away, and you're left with a little bit of scar. So it's not fully reversible, but you do because the axon is okay, once the inflammation dies down, transmission can continue. It's not as fast as it was because you've lost that myelin in that area, and it's scar, so you can't remyelinate. Yes?
So why is MS more common in women than in men?
That probably has to do more with the genetics. It is more common in women. It tends to be between ages 20 to 50. We don't understand the complete etiology. We know that there is a genetic component, and HLA-DR2. So remember that HLA, human leukocyte antigen, codes for MHC, and the DR2 codes for an MHC2 molecule, or maybe it's MHC1. So what happens is that this interacts to increase the autoimmunity. So these lymphocytes and macrophages are autoimmune. Something has triggered them to recognize myelin as foreign and start to attack it. So having a certain genetic makeup seems to be involved in that. The other is virus. Many times people will get MS after a recent viral illness. I actually have a friend whose daughter just developed MS after Epstein-Barr virus. She had mono, and they just thought the mono was causing fatigue, and she didn't want to move. She felt weak. Turns out that she actually developed MS after mono. So something, and there's this idea of molecular mimicry, that there's some antigens and viruses that are similar to myelin. Once you've primed the immune system against that virus, once that virus is eliminated, the immune system continues its attack against myelin because they look similar. So that molecular mimicry. So the etiology is a combination of genetics and environment, and it's not 100% understood. We can't predict who's going to get MS. Am I running out of time? I am. Okay. Guillain-Barré is a demyelinating disease in the peripheral nervous system. It's actually been associated with Zika virus infection. Sometimes people after Zika virus will get Guillain-Barré syndrome. Similar pathogenesis, except that Guillain-Barré tends to be a defined period of time, and then it does go away. And then neurodegenerative diseases. These are a group of diseases where functionally related neurons die, usually from some kind of protein aggregate. So Alzheimer's, they get these A-beta plaques. Parkinson's, alpha-synuclein aggregates within the cells. So Alzheimer's disease, you get loss of cortical cells. So you get cognitive deficits, memory loss, general attention disorders from cortical cells. In Parkinson's, you lose dopaminergic cells in the substantia nigra. And this is a region in the base of the brain that projects into the basal ganglia, which controls motor coordination. So people with Parkinson's get tremor, they have difficulty initiating movement, and it's because of the loss of dopamine in the caudate and putamen, which is the basal ganglia, part of the brain that helps make those movements coordinated. ALS is a loss of motor neurons. And then Huntington is a loss of, it's a very discrete area of the brain that's involved in suppressing movements. And so people with Huntington's have these crazy tics and what they call choroid movements. They look like they're kind of like dancing. They just can't inhibit loss of motor inhibition. So So you can see there's a lot of different functional outcomes. But neurodegenerative diseases are all grouped together because it's the functionally related neurons that die. Not regionally related, but they're all the same function. All right. See you guys on Thursday. Have a great couple days. Thought it was